Welcome, everyone. I'd like to share, as Dana said, some of my experiences with ProFound AI. I've had the opportunity to have it in our practice for just over 3 years now, and we looked at our practice outcomes as a result of its utilization during the first 2-year period. And I'd like to share that with you, as well as some of my observations and how we use it in our practice, and show you some interesting cases. Next slide. So I'd just like to introduce our breast practice to you. Boca Raton Regional Hospital is a not-for-profit hospital. It has a main breast center, which is housed on the property of the hospital. There's a main breast center, and then we have 2 smaller satellite fixed sites. We also have a single mobile mammography van. Currently, we're utilizing 11 GE Pristina mammography units, and we're offering 100% DBT to our screening patients. Each of the exams is reviewed by one of 9 MQSA certified, fellowship trained, dedicated breast imagers with an average of 22 years of experience and a range from 10 to 47 years. All our screening exams are read real time while the patient is in the center. And if the patient needs additional imaging, we will do that before she leaves. So she leaves knowing her final results and recommendations for follow-ups. We also give her information about her personal breast density and lifetime risk to develop a breast cancer. And we do that because we have endorsed individualized screening for many, many years, depending upon a patient's level of risk. We're performing more than 25,000 screening exams per year and identifying and treating more than 700 new breast cancers per year. Next. In 2014, we implemented digital breast tomosynthesis throughout our practice. We knew of the benefits of increasing cancer detection by 30%, as well as a decrease in recall rate by up to 40%. But with these benefits come challenges, and the number one that we recognized was that there was an increase in reading time by up to 2 times greater than that for digital mammogram. With the hundreds of images that we're looking at, scrolling through them, looking for subtle signs of cancer can cause mesmerization with fatigue and burnout of our radiologists. And this is something we just cannot afford to let happen. And even with the benefits of DBT, there are still missed cancers in our practice, and there are still unnecessary recalls. So we look to artificial intelligence, and specifically to ProFound AI, to see whether it could help us in the performance of our practice. Next. This was information that was given to me by a friend of mine, Dr. Randy Hicks, out of Flint, Michigan. He described a 2D digital mammography practice where a radiologist would be reading 100 screening exams per day. There are 4 images per exam, so that radiologist is seeing 400 images per day, or 2,000 images per week. That equates to 80,000 images per year. But when that same radiologist transitions to 3D DBT imaging and continues to read 100 cases per day at 280 images per exam, that equates to 28,000 images per day, or 140,000 images per week, or 5.6 million images per year. So in 2.9 days of reading DBT, you're going to see as many images as you would have seen reading 2D mammography for a period of 1 year. So obviously we need help. We're drowning in images. We're looking for subtle findings, interval changes, and most of the time, 90% of the time, there's no cancer on the exam. So it's hard to keep focused. And we look to AI to help us regain that focus. Next. So iCAD's ProFound AI analyzes each 1 millimeter thick slice for the presence of masses, distortions, calcifications, and asymmetries. If an abnormality is found, it is segmented and then classified. The finding will be given a lesion score, and the entire exam will be given a case score. Next. So the lesion score is calibrated from 1 to 100%. And the computer refers back to the database looking for items with similar findings. And the ProFound AI lesion score reflects the algorithm's confidence that the finding is malignant. So the higher the number, the greater the likelihood that you're dealing with a malignancy. The lower the number, the less likely you're dealing with a malignancy. Then the case score is calibrated from 0 to 100%. And again, the computer refers back to the database looking for tissues of similar appearance. Again, the score represents the confidence that the case contains a malignancy. Again, the higher the case score, the greater the likelihood and the greater the confidence that you're dealing with a malignancy. So if we look to the right, the area of architectural distortion is segmented, and it's given a lesion score of 97%. Down below, we have a group of calcifications also segmented and given a lesion score of 23%. So the architectural distortion is of greater concern to the artificial intelligence than the group of calcifications. Down below, the case score for this case was 99%, and there were 2 findings. Next. This graph shows the performance of ProFound AI version 3, which we are currently using on our GE systems. The blue bars represent non-cancerous or benign lesions. The yellow bars represent cancers. And we can see that about 80% of malignancies will have a case score of 50% or higher. And about 80% of benign findings will have a case score of 50% or lower. But you'll have to notice that a small number of cancers will have a low case score, and a small number of benign findings will have a high case score. And it's up to the radiologist to use their diagnostic skills to determine which benign appearing cancers need to be evaluated. Perhaps they presented as new findings, or perhaps they presented as interval change in size, growing lesions, to determine the need for further evaluation of that finding. And also, some of the benign findings, such as a surgical scar, may present with a high case score, but we have the opportunity to have knowledge about the patient's clinical history as well as prior mammography to determine whether the lesion needs to be evaluated or not. You have to remember that the ProFound AI is only looking at one static point in time. It doesn't have benefit of the clinical history for that patient, and it doesn't have benefit of the prior exams. And that's where the importance of the radiologist's knowledge comes in to determine the need for further evaluation. Next. So this is the data from the ProFound AI reader study. The reader study was performed with readers evaluating 260 cases. There were 24 readers, half of which were dedicated breast radiologists performing more than 75% of their practice reading mammography and breast imaging. The other half was general radiologists who also read mammography. These cases were read both with and without artificial intelligence and separated by a period of time. The sensitivity for both on the case level as well as the lesion level was 8% greater with AI and 8.4% greater with AI compared to without AI. The specificity also showed improvement of 6.9%. The recall rate decreased by 7.2%. The area under the receiver operating curve improved by 0.57, and the reading time decreased by 52.7%, a significant findings here at all levels. Next. So this graph to the left shows the performance of these 24 readers without using artificial intelligence. And as you can see, there's great variability, both in sensitivity as well as specificity and reading time. And the reading time is demarcated as the size of the circles that you see. We look to the right, and you see the change in performance when readers are using the artificial intelligence to assist them in their diagnosis. And you see that there's significantly less variability. The circles move together. There's improvement in sensitivity. We see all the circles moving up, and improvement in specificity. They all move to the left. And there's decrease in reading time, and the circles got smaller. So it's really interesting how everyone was impacted by the use of artificial intelligence when identifying and reading these 260 cases. Next. If we look at the difference between breast radiologist performance and that of the general radiologist, we can see the area under the receiver operating curve increased for both, as did the sensitivity and the specificity, and both groups benefited by decreasing the reading time. Next. With regards to dense breasts versus non-dense breasts, again, the performance improved for both groups. The area under the receiver operating curve increased. The sensitivity increased for both groups, as did specificity, and both groups benefited by decrease in reading time. Next. So let's look at some cases. Case number 1. Next. So this patient came to us, had fairly fatty breast tissue. We see several nodular densities in the upper outer aspect of the breast. The ProFound AI identified the more anterior lesion as demarcated with the red arrow. It was given a case score of 84% and a lesion score of 67%. So fairly significant concern that we're dealing with a malignancy here in 2020. As was our protocol, we went to targeted ultrasound looking for this area, and we found a very small solid nodule. As we were just at the early time of our utilization of AI, we gave it a BI-RADS 3 assessment and recommended the patient come back in 6 months' time. Next. The patient came back in 2021, and we can see visually that the nodule had increased in size slightly and increased in density. The case score was also increased. It was identified on both views with a lesion score of 30% and a lesion score of 76% on the craniocaudate view. Next. We repeated our targeted ultrasound, and we can see that the lesion increased in size. It was round, irregular. It demonstrated an echogenic rim and significant tissue stiffness on shear wave elastography. This was percutaneously biopsied and was found to represent a 6mm invasive ductal carcinoma of intermediate grade. And I display here the MIP image from our staging breast MRI, and you can see the 2 enhancing lesions in the posterior lateral left breast. Only the anterior one was identified and marked of concern by ProFound AI. The more posterior benign intramammary lymph node was not identified. Next. Case number 2. This patient had scattered fibroglandular densities. There was a small sub-centimeter rounded nodule identified in the posterior 12 o'clock position of the breast associated with a small peripheral calcification. Next. This was identified by ProFound AI and given a case score of 94% with a lesion score of 60%. Next. Again, we went to targeted ultrasound, excuse me, and found a small solid nodule with an echogenic rim, an increase in local tissue stiffness with shear wave elastography. And this was biopsied and found to be a 6mm low-grade invasive ductal carcinoma and DCIS. Next. Case number 3. This patient had scattered fibroglandular densities. A small area of architectural distortion was identified by ProFound AI in the lateral subareolar aspect of the breast. The case score was 78% and the lesion score 60%. Next. The lesion was also identified on the MLO view and given a lesion score of 42%. I think this is a very subtle finding and would be very difficult to identify should you not have the assistance of ProFound AI to help you refocus your attention to a small irregular finding. Next. We went to targeted ultrasound and found a small hypoechoic solid mass also associated with tissue stiffness. This was biopsy percutaneously, and a 3 millimeter invasive lobular carcinoma, pleomorphic type, grade 2, was identified. Next. Case number 4. This patient had high breast density, busy breasts, nodular pattern. The case score was 32%, so not as significant as we have previously seen, and a lesion score was 23%. A small area of distortion was seen in the 2 o'clock position of the breast by ProFound AI. Next. She was evaluated with spot compression imaging as well as targeted ultrasound, and ultimately a small suspicious anti-parallel solid mass with shadowing was seen in the 2 o'clock position of the breast corresponding to the AI finding. This also demonstrated significant tissue stiffness with shear radial elastography and was found to represent an invasive ductal carcinoma grade 1 at the time of biopsy. Next. Case number 5. This is a case I recently had the opportunity to evaluate after she was called back for suspicious findings in the right breast. You can see she had heterogeneously dense tissue on the 2D and synthesized mammographic views. The ProFound AI identified an area of distortion in the lateral retroareolar aspect of the breast. The case score was 62%, and the lesion score was 45%, and the lesion was identified in 2 views. Next. We did spot compression imaging, which really didn't show much findings. There was dense breast tissue, but really no real distortion seen mammographically. However, when we went to targeted ultrasound, we found a very suspicious solid mass with echogenic rim, distal shadowing, and significant increase in tissue stiffness. And this was found to be a 2.5 centimeter invasive ductal carcinoma. So not anything that's subtle, as in the other cases that I have shown you, but something that is large and prominent. And unfortunately, next, we'll look at the next slide. I look back at the 2022 finding, and again, the 2D and synthesized mammogram to the left shows little change from the current mammography. However, the ProFound AI identified the lesion in both views 1 year previously. The case score at that time was 34%. The lesion score was 26% on both views. So the distortion had been present at least 1 year and was identified by AI, whereas the radiologist did not evaluate the study at that, evaluate the finding at that time. Next. And I went back even 1 year more, and again, the AI identified the lesion with a case score of 51% and a lesion score of 38% in 2021. So 2 years prior to our evaluation of this finding, the AI had picked it up. In 2021, it was only seen in 1 view. In 2022, it was seen in 2 views, as well as in 2023. So what I'd like to relate to you here is that if you see persistence of findings on sequential years, you really need to evaluate that area and not let it go by, because the AI is seeing things that we are unable to appreciate. And if you're seeing it in 2 views, even more so. So I think an interesting case just to document and to let you know that not only will it help you find subtle small findings, but it will help you find subtle large findings as well. Next. So how about the false positives and false negatives? Certainly, we have to think differently when you initiate the AI into your practice. It's not CAD for 2D. You're going to see significantly less marks than we did with 2D CAD. There are going to be some false negatives. You know, nothing is 100% perfect. There will be predominantly, and I haven't seen that many of them, but mostly they've been benign appearing cancers. But it's up to the radiologist to use your diagnostic skills to look at prior exams, determine whether the lesion is new, or if it's grown, or is it something that's stable that can be ignored. If it's new or it's grown, you're going to want to evaluate it. With regards to false positives, again, significantly fewer false positives than we saw with 2D CAD. Some calcifications can result in a lesion being marked. If you have motion on your images and patient has clips that may simulate the presence of linear calcifications, and the AI is thinking that maybe this is an area of DCIS. A parenchymal scar may be marked, and you may know that the patient had a lumpectomy in that area, but remember the computer does not have the benefit of prior images or benefit of knowledge of the patient's clinical history. And then at times, vascular calcifications will be marked. For all the calcifications that we see, it's a small number, and you're easily able to discount these findings, which are false positives, because you have knowledge of the clinical history as well as benefit of prior exams. Next. So this is what I presented at the European Congress of Radiology in Vienna in March of 2023. The title was Real World Breast Cancer Screening Performance with Digital Breast Tomosynthesis Before and After Implementation of an Artificial Intelligence Detection System. Next. The purpose of our study was to assess the breast cancer performance of dedicated breast radiologists both before and after implementation of an AI detection system with digital breast tomosynthesis. Next. Our study was an IRB-approved, HIPAA-compliant observational study. The pre-artificial intelligence period began in March 1st, 2018 and ran through February 29th, 2020. During that period of time, we performed 54,440 digital breast tomosynthesis screening exams and identified 383 cancers. The post-artificial intelligence period ran from March 1st, 2020 through February 28th, 2022. And during that period of time, we performed 48,742 digital breast tomosynthesis screening exams and diagnosed 399 cancers. Next. This is a graph of our number of screening exams performed per month. The red vertical line demarcates the initiation of artificial intelligence in our practice. And you can see shortly thereafter, our screening numbers went to 0 due to the impact COVID-19 had on our practice. For a period of 6 weeks, we performed no screening exams at all. Next. And these are our results. We saw an increase in our cancer detection rate from 5.77 to 7.08 cancers per 1,000 women screened, which was an increase in 23%. We saw no significant change in our recall rate, which was at 6.96% post-AI. Our PPV1 also increased by 23% and was found at post-AI to be at 10.17%. Our sensitivity improved by 6% and post-AI reached a level of 86.47%. And our specificity showed little significant interval change after the use of AI. Next. So here's a graph of our 9 individual radiologists. The horizontal red line demarcates the benchmark of greater than 2.5 cancers per 1,000 women screened. The pre-AI bars represent the radiologist's performance prior to AI, and then the dark blue bars represent their performance post-AI. And as you can see here, every single radiologist showed improvement with the use of artificial intelligence, such that we saw a pooled improvement of 23%. I want you to specifically look at reader number 4. This woman found the most cancers pre-AI, but also increased her cancer detection rate with the use of artificial intelligence. She had confidence and trust in the product and increased her cancer detection rate. I want you to also look at reader number 8. This reader is different. She had a good cancer detection rate prior to AI, but showed no significant interval improvement with the use of AI. So it must be a matter of trust that she did not see changes in her practice as all other radiologists did. Next. If we look at the recall rate or abnormal interpretation rate, again, the horizontal lines demarcate the benchmark of 5 to 12%. We can see that all radiologists fell within benchmark or below benchmark, both with and without the use of artificial intelligence, such that there was little significant change in recall rate for all radiologists when the results are pooled. However, let's look back at reader number 4 again. She increased her recall rate, but remember, she increased her cancer detection rate. So AI was working for her. She gained confidence in it. Her recalls were appropriate and accurate, and she found more cancers. However, if we look at reader number 8, her recall rate also increased. But remember, her cancer detection rate showed little significant interval change. So she has not adjusted as well as the other readers to the use of AI. She's not as accurate in her recall rate, and she probably has a lot of false positives coming back in. Next. This is the graph of sensitivity, both pre and post AI, the benchmark being greater than 75%, and we see all readers performed above benchmark levels with the use of artificial intelligence. And overall, we saw a pooled improvement in sensitivity by 6%. Next. This is specificity. Again, benchmarks were reached of greater than 88%, both before and after implementation of AI, but there was little significant interval change in specificity as a result of implementing artificial intelligence. Next. And this is the positive predictive value 1, or the number of cancers identified on patients who are recalled from screening. Again, benchmarks are between 4 and 8%. We showed improvement by 23%, which mimics the improvement in cancer detection rate. Next. So we're going to shift gears here a little bit and talk about breast cancer risk determinants. We know from screening back in the late 80s, when we first started, every woman would be requested to come in beginning at age 40 and come in on an annual basis for as long as she remained healthy. We also took information about our personal and family history, but really didn't do anything more with regards to the patient's level of risk. Every patient was treated the same with annual screening mammography. By the mid-90s, BRCA1 and BRCA2 were identified, and we learned of the significant increase in breast cancer risk for these patients, and we began screening them early because they developed their cancers early. They had more aggressive cancers. So we also added supplemental screening to these patients to assist in early detection, predominantly with the use of breast MRI. By 2009, we became knowledgeable about the impact breast density has on the sensitivity of mammography. We know that there's a masking phenomenon because the cancers cannot be identified in the dense breast tissue. But we also learned that patients who have the highest breast density are also at elevated risk to develop breast cancer. And this risk can be up to 5 times greater than a patient who has fatty breast tissue. So we began screening these patients with supplemental screening, most notably in our practice being screening breast ultrasound. And now we're hearing even more that the mammographic parenchymal pattern, the complexity of the appearance of the mammogram, may be a sign of a patient's level of risk. So this is greater than what we're able to comprehend with regards to breast density. There's more in the mammogram than just breast density. And the artificial intelligence is able to identify these patterns, which may place that patient at increased risk, where we can offer them supplemental screening. Next. So ProFound AI's risk model determines the 1 to 2 year absolute risk to develop a breast cancer after a normal negative mammogram. And the computer looks at each mammographic image for the presence of masses, calcifications, densities, shapes, textures, patterns, and asymmetry. And this is in addition to the overall breast density, as well as the patient age, which comes from the DICOM header. And after looking at these findings, it places that woman in one of 4 categories of risk. And what's good about this is that there's no human input. It purely comes from the mammogram as well as from the DICOM header. So the workflow is very simple. There's no data entry. There's no room for human error. There's no questionnaires to be filled out. Next. So let's talk a little bit about lifetime risk versus short-term risk. The 1 to 2 year risk model predicts cancer by the next screening exam or predicts that the patient may develop an interval cancer. And we use this to recommend supplemental screening. And patients, knowing that their risk is in the short term, may be more motivated to comply with these screening guidelines than patients who have a lifetime risk to develop cancer. The 5-year risk model we use to implement risk reduction strategies such as tamoxifen or aromatase inhibitors. And then the lifetime risk, we identify women who qualify for annual breast MRI supplemental screening due to the elevated risk over that period of her lifetime. But we know that only a small percentage of women who have high lifetime risk actually comply with supplemental screening guidelines. Next. If we look at the performance of the ProFound AI risk for DBT, the area under the receiver operating curve is 0.83. This is significantly better than that for the clinical risk model of Tyrer-Cuzick 8 at 0.62 and the Gale model at 0.56. So the clinical risk models are population-based. They're really not looking at that individual woman to see what her personal level of risk is, whereas ProFound AI risk is actually looking at that woman's breast tissue and actually has probably a much better chance of identifying who is at risk because of the complexity of her tissue. And I think that this is something that's really important and will be impactful for us in the future as we become more comfortable working with this model. Next. So as I said, the ProFound AI risk model places a woman into 4 levels of risk: low, general, moderate, and high. And as we have been working with personalized screening, depending upon risk for many, many years, what I would do with patients of low risk is recommend she come in for her screening mammogram DBT. If she's at low risk, perhaps she can extend the time period for her return from 12 months to perhaps 15 months or 18 months. However, if she's dense, I would recommend she have screening breast ultrasound due to the impact of the masking phenomenon and the poor sensitivity of the mammogram. Those patients at general and moderate risk, we would recommend that they have annual DBT screening. We would recommend that they have a formal risk assessment to discuss the needs for supplemental imaging, which may be with ultrasound, it may be with contrast mammography or molecular breast imaging. And then patients at highest level of risk, again, we recommend annual DBT screening, a formal risk assessment to determine the need for genetic testing, and then supplemental annual screening with breast MRI. Next. So I observed a great difference in our practice as we were diagnosing new cancers. And I looked at 90 patients who had newly diagnosed breast cancers, and they were evaluated by the Gale model and ProFound AI risk. And they were categorized with the Gale model into average, intermediate, or high risk, and with ProFound AI risk into low, general, moderate, or high risk. With the Gale model, only 6% of newly diagnosed cancers were actually categorized into intermediate or high risk, where we would have recommended that they have a formal risk assessment and supplemental screening. 94% were categorized as average risk. So obviously, the clinical risk model was not accurately identifying which patients are at risk. However, with ProFound AI, 85% of these 90 cancers were categorized as general, moderate, or high risk. So we would have recommended, had we known that, formal risk assessment and supplemental screening in these patients. Only 15% were found to be at low risk with ProFound AI. Next. So let's look at a few more cases. Case number 6. This patient is at low risk and also low breast density. So I would recommend that she have DBT. She can lengthen the time between her screening exams. She does not need a formal risk assessment or any supplemental screening. Next. Case number 7. This patient had low breast density, yet she was considered at high risk. So we would recommend for her formal risk assessment and supplemental screening with one of our additional imaging tools. Next. Case number 8. This patient had high breast density but was considered at low level of risk. I would recommend annual DBT for her, as well as supplemental screening with breast ultrasound due to her breast density. Next. Case number 9. This patient had high breast density. You can see a complex mammogram with multiple masses, patchiness. She was considered at high level of risk. So for her, we recommend annual screening, we recommend formal risk assessment, and we recommend supplemental screening. Next. Case number 10. This case, this patient was imaged in 2014. She had low breast density. No significant finding was identified on the craniocaudad mammogram. If you notice, her level of risk was a high moderate level. Next. She came back in 2016. Her risk increased, and she had developed an invasive cancer posteriorly in the breast. Had we had counseled her in 2014, certainly we would have recommended that she come back in 1 year's time, not 2 years' time. And we may have recommended that she have supplemental screening at that time to include either ultrasound, molecular breast imaging, or contrast-enhanced mammography, and possibly even breast MRI. So we would have had the opportunity to identify this cancer potentially at an earlier time with lesser treatments required. Next. So what's the impact been of iCAD on our practice? Well, it's given us the opportunity to find small, clinically relevant invasive cancers at an earlier stage. And this gives us the opportunity to offer these patients more and less aggressive treatments. We are seeing in our practice fewer mastectomies being performed, smaller lumpectomies, despite the fact that they're finding more cancers. Our chemotherapy practice is flat, as I've heard. We're doing less chemotherapy, less radiation therapy. And this is because we're, I believe, entering into a whole new era where we're able to find these 3, 4, 5 millimeter cancers, and we're going to have to revise the way we end up treating these patients, because we are able to find these perhaps 1 or 2 years before we would have been able to identify them without the benefit of artificial intelligence. We also have noted that ProFound AI has assisted us in triaging of cases and improving our departmental efficiency as a result. So the radiologist can focus more attention on the more difficult cases with higher case scores and breeze through a little bit more easier those with lower case scores. And with this, we can reduce radiologist fatigue and burnout of our breast imagers. We feel more confident, or feel more effective and less burdened by the thousands of images that we're seeing on a daily basis. And perhaps in the future, the use of AI may contribute to changes in screening protocols depending upon the mammographic risk. So thank you for that, and thank you for your attention.